Good afternoon, everybody. I, Dr. Asad Riaz, Fellow Interventional Cardiology, working in PIMS Hospital. Today, I'm going to present my case, successful retrograde revascularization of chronic total obstruction of left main stem. Okay. We have 60-year-old female diabetic hypertensive had coronary artery bypass graft 20 years back presented to OPD with complaint of angina class 3 despite optimal medical treatment. We did the echocardiogram, we showed normal kinesis, and after that we planned and we will go for angiogram depending upon her symptoms. And we did the angiogram, and angiogram showed there is non-significant disease involving to the right coronary artery, and the left system we cannot engage with left Judkins catheter because of total obstruction of left main stem. After that, we advised a CT angiogram, and CT angiogram showed that there is unvisualization of ostial left main stem to proximal LAD, along with there is atractic left internally memory artery graft to the LAD. And we engaged. And then we planned that the most likely culprit lesion, this is not working. The next slide, next video, please. Actually, the slide which is not working here, it's a video. Here we engage the SVG, which is we attach to the D1, and we viewed from SVG to LAD left system, and we found that there is significant disease involving to the mid LAD. And then we planned that this is the most likely culprit artery which is causing angina to the patients. And then we planned our strategy accordingly. We planned retrograde revascularizations to the culprit arteries. We had retrograde wiring with pilot 200 along with over-the-wire balloons, which is after retrograde wiring, we plan to externalize this wire through the right radial approach by snaring. With the help of this snare, we are able to also externalize the over-the-wire balloon, and with the help of that balloon, we are able to balloon the LMS and LAD. After that, we did the anti-grade wiring with the BMW, and we did prepare the lesion by using semi-compliant balloons. Once the lesions are prepared, then these are the slides showing that we are preparing our lesions with semi-compliant balloons. And here's the final results after lesions preparations with the semi-compliant balloons. We deployed 2 DES stents from ostial LAD to mid LAD, and those stents then we post-dilated with higher balloons with at higher pressures. We can see these are the balloonings, and all those stents are post-dilated. After post-dilatations, we can see we have a final results, and along with we also did the angiogram, and we see our graft, which is SVG to D1, is also functioning normal. After following patients become asymptomatic, and her quality of life improved a lot. Key learning points: CTO antigrade is better than retrograde, but retrograde is valuable in certain cases like this one. Venous graft can be used for retrograde C2 intervention. We also should perform retrograde C2 interventions. More case you do, better you become.
I hope not when antigrade can be done. You should
sorry,
do retrograde just because you want to learn if antigrade can be done.
No, sir.
That's what you should add. Very, very excellent case. Excellent.
Sir, any questions, sir?
Excellently done. Very good.
Sir, thank you.
Did you use pilot 50 or pilot 100 for the
Sir,
retrograde?
Pilot 200.
Did you give any secondary curves to the wire to get into the diagonal and up into the LED? Any special preparation to the tip of the wire?
Yes, sir. We did the preparation for the tip of the wire. The tip is slightly bent for CTO preparations of the tip, like slight bend of the tip at the tip, and then after preparation of the tip, we went through retrogradely.
Very well done.
Sir, thank you so much.
Are there any more comments or questions? Well, they didn't show any Lima. You can ask the presenter, Lima.
There was no Lima.
Lima, he just mentioned it was atretic. He mentioned it was atretic.
Sir, Lima was atretic, which was showed on CT angio. CT angio be done for the. Sir, the S.
Will this again cause the vessels will become atretic again on either side? Because there is a good flow from the one and the other from the graft and the LED.
Sir, Lima is.
In such situation, if there is a competitive flow, so that both of the vessels they suffer. So what will be your strategy?
Sir, SVG graph is working functionally. We did angiogram after stent deployment. The SVG already working.
But if that is functioning, that is the reason that there will be competitive flow and the things will get worse with time.
Sir, but we have followed the patient, but the patient is symptomatically improved a lot. Sir, any other question?
Okay, thank you, ladies and gentlemen, for an amazing session. And I'd invite Dr. Shamim Siddiqui to take over for the next fellows session. Thank you, everyone. We finished on time because of me, obviously.